From the American Neurological Association, I'm Adeline Goss. This is ANA Investigates. On our December show, we talked about ethical issues surrounding brain-computer interfaces. We'll pick up the topic again this month with a discussion about one type of brain-computer interface, neuroprosthetics. Our guest is Dr. Edward Chang, professor and chair of neurological surgery at the University of California, San Francisco. Dr. Chang is an expert in brain mapping during neurosurgery, the aim of which is to preserve brain areas responsible for language, speech, movement, emotion, and other important functions. His research focuses on neuroprosthetics, including those that can restore speech in people with speech disorders. As we'll talk about today, this research raises interesting ideas about the neural representation of speech and language and the ethics surrounding brain-computer interfaces. Dr. Chang was interviewed by ANA producer Dr. Mandy Jagolino-Cole of the University of Texas Health Science Center at Houston. Here's Mandy.
Welcome, Eddie, and thank you so much for taking the time to speak with us.
Hi, Mandy. It's great to be with you.
Before we get into your work with brain-computer interfaces, I'd like to ask you about language as you encounter it during your neurosurgeries. For these surgeries, you are often resecting brain tissue that's near patients' language areas. These are really fascinating surgeries. You'll have patients awake on the operating table, engaging in cognitive tasks while you stimulate their brains to preserve eloquent areas. What have these surgeries taught you about the localization of human language? Is it just like we learned in medical school? There's a Broca's area, a Wernicke's area, and the arcuate fasciculus?
You know, this is a really interesting question for me because this is basically how I got into this whole realm of language neuroscience and brain-machine interface. A lot of the insights that we've had towards understanding how language is processed in the brain, for me, started in the operating room, training at UCSF, and being exposed to a lot of awake brain surgeries, both for epilepsy and removing tumors. And these cases, you know, when I first saw them, it was really surreal. It still feels that way to have a patient awake there as you're testing using electrical stimulation to probe all of these areas that we've learned in the textbook called Broca's area, Wernicke's area, the arcuate fasciculus, these areas that you've mentioned. And the thing that has been the most surprising to me is, in fact, that a lot of what we did learn in medical school is really just the tip of the iceberg and partly wrong, actually. It's, I think, in many ways, a really oversimplification of how language works in the human brain. And just as an example of this, we now know that these areas in the inferior frontal gyrus that we call Broca's area don't seem to be critical for speech production as much as they are involved both with production and comprehension at higher levels. But it's clear that it's not really that critical for the act of speech articulation, whereas Broca himself actually really postulated that that was its functioning. In fact, he termed it as the seat of articulation. And the same thing could be said for Wernicke's area. It's clearly not just one monolithic cortical area that is involved with language comprehension. As many people know, injuries in Wernicke's area produces language production deficits just as much as it can with comprehension deficits. And we're only starting to really understand that dichotomy. It's not one monolithic area, but actually an area that has multiple functions. So it's a really exciting time to be in the field of language neuroscience because I think it's what we're going to see in the next 5-10 years is a lot of the basic facts and ideas about how it works are going to change for the textbooks.
That is indeed fascinating. Now let's jump from brain mapping to neuroprosthetics. In 2021, you and your team published the first case of using a neuroprosthetic device to restore communication in an anarthric patient, someone who had lost the ability to speak several years before. How did this device learn what the patient wanted to say?
So I'm going to talk a little bit about this project that we started called the Bravo trial, which is a clinical trial as a pilot trial to test the feasibility of a technology, a device, to restore words to people who have lost that because of paralysis. And this demonstration basically occurred with the first participant in the Bravo trial. His name is Pancho. He goes by Pancho. And he suffered a very severe brainstem stroke almost 15 years ago. He was in a car accident, a very severe one, actually walked out of the hospital that same day, but then the next day collapsed and was taken to a hospital, was diagnosed with a very severe vertebral artery dissection and a brainstem stroke. He was in a coma for about a week, and when he woke from the coma, he had full consciousness, but realized that he had lost the ability to speak and also was paralyzed in his upper and lower extremities. And he has lived actually in a care facility for the last 15 years where he has very limited movements, but actually has been able to thrive in his life by able to communicate with what we call assistive and augmentative communication devices. These are devices like the Tobii Dynavox or other things that allow people to type out letters and words one by any kind of residual muscle movements. In the case of Pancho, he has a stick that's attached to a baseball cap, and he can actually type out letters and words using some of the residual neck movements and head movements. So we were really fortunate to meet Pancho because he was really one of the first people in the world to have a device implanted for the purpose of restoring speech. He's not the first, but what he accomplished in this trial was that he was the first one where we could get successful decoding of full words and sentences. And that's the milestone that I think he gets the credit for, which was really a pioneer in this. About 1 to 2 decades ago, there had been some previous trials where microelectrode technologies from Phil Kennedy and some of his colleagues were inserted into parts of the brain to try to restore speech sounds and more. However, while they were successful in generating sounds like vowels, it never was able to create things like full words or sentences or in a way that was intelligible. So the particular approach that we took was different than some of the approaches that had been done previously. So we leveraged some of the technology and devices that I was very familiar with from epilepsy surgery. We call this kind of approach electrocorticography. We oftentimes put implanted electrodes on the brain surface that can record the EEG from the brain surface and then help us localize the seizure to help figure out where it's coming from and then resect that area. We've been doing this for decades. One of our insights from this experience was with high density electrocorticography electrodes from the brain surface. About 6 years ago, we were able to decode every consonant and vowel from electrical activity recorded from people speaking while they were having these electrodes recording from their brain. And once we had that knowledge, we thought this might actually be a good time for us to consider the possibility of leveraging that information to read it out for someone who's actually paralyzed. And so that's why we started the Bravo trial, just assessing the proof of principle and feasibility of this. And so as time has gone on, the Bravo trial has now recruited 3 patients, and it's a very exciting time to see how far this technology can take us. One of the big challenges that we had going into the Bravo trial was recording the brain activity and then translating that into words and language. So the signals that we can record from the brain surface, this electrocorticography signal, looks like EEG. It looks like squiggly, wavy lines. But within that signal, there is a secret code. And to break that code, we used a lot of artificial intelligence, basically machine learning, to translate those electrical patterns to the associated words and sentences. Again, it's something that you can't see with your eye, but really does require a sophisticated algorithm that really didn't even exist 5 years ago.
Definitely looking forward to learning more about this trial and the discoveries that you all find. I have a question about localization again, to bring us back to that topic. You mentioned that Pancho's injuries were in the brainstem. And maybe we don't know this yet, but is neuroprosthetic device something that we could use in the future to augment communication for patients with cortical injuries, say in some of the areas connected with speech?
That's a really good point. So right now, what we're looking at in our Bravo trial is patients that have either had a brainstem stroke or other conditions where we have reason to believe that they have normal cognition. And in fact, patients that we think also may have residual motor cortex activity. What you're asking about is a really fundamental question about if the cortex itself, the processor of the language commands, is in fact injured itself, not just the connections from that part of the brain to the vocal tract. Is it still possible to do that? And that is really going to be some of the things that we focus on in the coming years, which is how do you use some of the artificial intelligence actually to replace, for example, language, and how that interfaces with the rest of the brain that is processing a lot of the other things that interact with language, like our thoughts and cognition. And so, in many ways, that's a much harder question, but I don't see right now why that's impossible, especially I think at the rate that we're seeing things improving in terms of technology and engineering around language.
Inventing a neuroprosthesis for speech seems incredibly complicated, but at least many aspects of speech are somewhat mechanical or concrete than some of the other incredible things our brains do, like produce experience of vision or store memories or experience emotion. Do you think that neuroprosthetics could be invented to help patients overcome loss of brain function in these activities and areas?
Absolutely. So I think where we need to make a lot of progress is really improving the interfaces. It's a fascinating time right now because there's a lot of commercial interest in this, and I think that's driving a lot more expertise, engineering. It brings in people with really different skill sets to this challenge of how do you interface with the human brain in a way that's safe, stable, but also really high bandwidth and high performance. And to do that, we need devices that can interact with the nervous system in ways that are going to be really safe over time. And so as we solve those kind of problems and overcome those kind of obstacles, the more that we understand, like the internal processing and the subjective experience that all of us have related to memories or our emotions or other perceptions like what we see, what we feel. Um, Once we understand those codes, I think that there's a lot of reason to be optimistic that this kind of technology can help us restore function for some of these areas that are lost by injury.
Through your research, you've recorded an enormous amount of human brain activity. What issues around privacy have come up when you perform these very intimate monitoring of your patients' brains? Are there any important ethical issues you think your research brings up? For example, if we consider the idea of future neuroprosthetics to change personality or regulate emotion?
Well, this is something that we've been thinking about since day one, and it's not just us, it's people in our field, but also people who are not in the field that are also concerned about what the implications are. Being able to essentially translate brain activity into words, being able to decode that. And so, with the work that we've been doing, I've been trying to be as careful as possible that we're not really reading someone's mind. What we're really doing is we're translating the neural activity associated with the commands that normally control the vocal tract to generate consonants, vowels, syllables, and words. So, in that sense, everything that we've been doing has really focused on the intentional and volitional expression of speech and language. I think it's very easy to misinterpret it as, eavesdropping or tapping into, I guess, someone's internal thoughts, for example. I don't think we're there yet, and I don't know when that will happen because that's an extremely complex scientific process or a biological process that's likely to be very, very distributed across the brain. But there's no reason why, that's not possible. And so I think if we don't talk about it now, the research may sort of move so quickly that these things come to reality before we've had time to figure out what do we really want out of this and what do our patients really need.
Final question as we wrap up, what is your big vision for neuroprosthetics? How will these devices eventually help patients with brain injuries?
Well, I think that we are just starting to understand how we can use technology, implanted devices to interact with the brain to help restore functions that have been lost. We generally think of two categories, and for today, we might talk about three. One is reading out activity. So basically, how you can take activity that is involved, let's say with speech in people who have a brainstem stroke, to bypass the brainstem injury to a computer that can translate that thing into words by reading out brain activity. There's a whole nother class of neuroprosthetics that are designed to read in, meaning that they will use stimulation or other ways to activate neuropopulations and have that linked to an external sensor like an artificial retina for people with blindness. Perhaps the most exciting thing is to think about what is a neuroprosthetic for cognition. In some areas, I think we are moving close to that. As you know, that we've got a lot of technology for stimulating parts of the basal ganglia to ameliorate the symptoms from Parkinson's disease or essential tremor using deep brain stimulation. We're also starting to see devices in neuroprosthetics that are able to treat mood disorders like very severe depression and more. So there's huge potential to have technology and devices actually, restore a lot of lost function, help normalize brain circuits in ways that medicines or therapy are not able to do, not to replace them per se, but just really augment what we're able to do. And again, I think we're just really starting to see a lot of exciting things converging to really make this a reality.
Well, this is very encouraging, and this has been extremely enlightening. Thank you so much for sharing this important work and for sharing your perspectives on all of this.
It's been great to spend some time with you, and it's a very exciting time actually to be in this field. So happy to share this with you and your audience.
That was Dr. Edward Chang of UCSF, interviewed by Dr. Mandy Jagolino-Cole of UT Health. ANA Investigates is the official podcast of the American Neurological Association. The show's producers are members of the ANA Education Innovation Committee, chaired by Megan Ritchie. I'm Adeline Goss, podcast host and executive producer. Our program was produced today by Mandy Jagolino-Cole, Rohini Samaldrawar, and me, with help from Jen Hurley. You can access past episodes of the show and all of the ANA's educational programs at myana.org. That's it for ANA Investigates. See you next month.